Sorry.
whether, so tardive dyskinesia is the result of being on antipsychotics for a long time. So, is it worth being on antipsychotics on the long run because of the risk or not? So we'll go into that as well, so that you guys can understand a little bit of what's the rationale to decide to stay on treatment long term versus not. Okay, so I'll begin by defining what tardive dyskinesia is. So tardive dyskinesia is essentially a consequence of having chronic antipsychotic exposure. Antipsychotics are not the only medication that may cause tardive dyskinesia. It can happen with other drugs that interact with the dopaminergic system, but the most relevant drugs are antipsychotics. So that is first generation, second generation antipsychotics. First generation, things like Haldo. Second generation, things like risperidone. And it happens again when there is a chronic exposure, at least for 3-4 months, uh, and it results in involuntary movements anywhere in the body. Typically, it's going to be the tongue, jaw, the face, the trunk, extremities. Um, and the type of movement is going to be either choreiform, athetoid, or semi-rhythmic. So that is like some technicalities about the way the movement looks like. So movements can be repetitive and but slow, or can be more rapid. So typically it's of the choreiform and choreatetoid nature, but that's probably beyond the point. So I'm going to show you some videos so that you can get a picture of what tardive dyskinesia looks like. So I'm going to show you 3 cases. These are people that give consent for their videos to be released. And as I said before, it can happen anywhere in the body. So I'm going to show you examples of different regions, and this will be moderate severity. So this is, here you can see that there's in the facial area, so you see that in the perioral area, there's blinking, there's jaw, repetitive jaw movement, there's repetitive tongue movement and mouth movement. So it's called facial region, but the reality is that you can see this repetitive involuntary movement in all of those different areas in the face. This is another example of moderate severity. So here what you can see is that there is this involuntary puckering of the lips, and on the right side you can see that there's a twitching as well and semi-blinking. And last, I'm going to show you another example of tardive dyskinesia in the upper extremities. So as I'm gonna go in a little bit of detail in a few minutes, I'll show you how this should be assessed by the psychiatrist. And this is one of the postures that we asked people to hold during the physical exam. So what you can see here is that this person has this movement of the fingers, this rhythmic movement of the fingers, that and also actually you can see it on the legs as well. There are some involuntary movements in the legs, but it's most noticeable in the hands. Also, you can see it in the mouth. There's some uh, like some rhythmic movement of the jaw. So that is the consequence of chronic exposure to antipsychotics. Um, you may have heard the term extrapyramidal symptoms. You may or may not have heard it. So what happens is that the antipsychotic drugs, they interact with a chemical in the brain that's called dopamine. And dopamine is related to processing information about our world. So it's helpful to process information about our perception, what we see, what we hear. And in psychosis, it helps because those processes are not working properly, right? So that's why targeting dopamine is very effective. However, dopamine is also involved in other things, like in movement. So it regulates movement. So whenever we mess up with that aspect, of the system, that is when we experience, when we see all of these movements that are involuntary. And there are some movements that are involuntary that happen very early when you start treatment. Sometimes you take one dose of medication and you may have something that's called acute dystonia. Okay, so you take the medication and then hours, minutes to hours, you can have a contracture of the neck. Or sometimes it typically is on the neck, but you can also sometimes see it in the face. And in some cases, it can be dangerous. It can be in the eye, so the eye muscles may contract, and that's obviously involuntary. And that is something that's very easy to treat, but you need to treat it, and that can be an emergency. This is more rare with the newer medications. There's another off-target effect of antipsychotics that's called akathisia. So akathisia is something that is actually relatively common, and that is a sensation of pins and needles in legs, mostly in legs and arms. And that essentially what that looks like is that the person that has akathisia, they are restless, they cannot sit through a show because they have to stand up, they have to walk. Okay, so that's also a side effect of antipsychotics, and that doesn't need to that occurs can occur within days. So that's not a chronic, that's not because of long term. That usually occurs early on and typically gets better over time. Again, that's also something that can be treated, and that's different from tardive dyskinesia. There is another motor side effect of antipsychotics that's called Parkinsonism. So I don't know if you know anyone that had Parkinson's disease. So typically people that had Parkinson's disease, they have rigidity, they move slow, okay, and they have tremor. So those are the three main features of Parkinsonism. And that is something that can happen with antipsychotic medications. Typically that happens at the beginning of treatment. It persists. It's something that's easy to treat. And today, it's very rare that someone will have to live with it because there are things that we can do for it. And there are newer medications that don't have any of this off-target effects. But that's also another movement disorder that is not tardive dyskinesia. And then there's the fourth category, the fourth type of side effect of antipsychotics that's different from those that I described so far, and that is tardive dyskinesia. So tardive dyskinesia, it looks like what I showed you, looks like the videos that I showed you, is something that occurs after being on antipsychotics for several months. It typically looks like this rhythmic, slow frequency movements, very often in the face, but it can happen again anywhere in the body. It could happen in the vocal cords. So it can happen really anywhere where there's a muscle, it could happen. And that's what we're going to focus today. Now, how common is tardive dyskinesia? So tardive dyskinesia happens, it used to happen much more frequently with the older drugs. So those of you that may have had experience with antipsychotics, that may have known about antipsychotics decades ago, you may have seen this more frequently. So things like Halo, flufenazine, those are drugs that were that are associated with a lot of risk. So here is like the incidence and prevalence. So what this means is if you take like if you take a cohort of people, you take a group of people and you follow them for a year, how many of them are going to develop tardive dyskinesia? And here you will see that if you're with a first generation antipsychotic, it's going to be 6.5%. With second generation, 2.6. So you see second generations are much less risky. And that's why we prefer to use those drugs as opposed to the older drugs. And the prevalence means if you take a snapshot of the population, how many of the people that are on the first generation antipsychotics are going to present with tardive dyskinesia. So it's going to be about 30%. So it's actually quite prevalent. And second generation, it's going to be a bit less. So especially if they have never been on first generation antipsychotics. So clearly first generation antipsychotics are much more risky. So what happens is that, as you can see here, is not that this is not that small of the population, a small amount of the population that present with this. The problem is that it's underdiagnosed. So it's estimated about 60% is undiagnosed. And that is, it's a problem because there's treatment. And part of the reason why this is underdiagnosed is that up until 2017, there were no treatments for tardive dyskinesia. And people felt that, we can do anything about it, so I'm not even going to monitor. Things have changed. Now there are treatments, so it's important to monitor, and we'll go in a minute into how that should be done. Um, and the other thing is that now we have second generation antipsychotics. We have newer types of medications that don't put any risk, that don't have any risk of tardive dyskinesia. So, that might be another reason why we don't do enough screening. So here what you see is, what has been the trajectory over time. So if your experience is from decades ago, you see here how much first generation antipsychotics were being used, and you see that they actually made the large amount of the pie. And those are much more dangerous. In Risperdal came out, so you start seeing that there is an increment on the different options that you have. All of these drugs are second generations. They are much less risky. They are not zero risk, but they are much less risky. What is the problem? That you see that in general, the first generation antipsychotics go down, but the total amount of antipsychotics that's being prescribed goes up. Okay? So we are using way more antipsychotics than what we were using back like 20, 30 years ago. And what that means is that overall, these drugs that we are using now are safer, but we use them much more and they don't carry zero risk. There's a risk associated with it. So we are not out of the woods. TD is real and TD is something that has to be monitored. Now, why does it happen? So I'm going to explain it very simply. So um, what happens is that these drugs interact with dopamine, and what they do is that, dopamine is a chemical that's released in the brain. And then it goes from one neuron to another neuron. Okay, so it's released and then it's received. And under usual conditions, you're going to have some blocking. So what the antipsychotics do is that they block here. But then what happens is that if you are blocking too much, the body says, hey, what's going on? I should have more signal here. And then you're going to have more dopaminergic receptors. So that's why it's chronic. It's chronic because it takes some time for the body to upregulate those receptors and now get very sensitive to dopamine. And that is why you have this side effect. Okay? Not everybody is at the same risk of developing TD. There are going to be some circumstances that put people especially at risk. So the first one is going to be, how much have you been on antipsychotics? So, and this is just a matter of aging. So the older you are, you get more time on the antipsychotic. That's going to increase the risk. Treatment with anticholinergics. So things like Artane. These are drugs that are used to prevent some other side effects. If they are used chronically, that may increase the risk of TD. History of other motor side effects, the potency. So that's like there are some drugs that are more potent than others. And that doesn't mean that they're more efficacious, but it means that they target the receptor more tightly. So that that increases the risk. And let's see a question here. What about clozapine? That's an excellent question. Okay, so clozapine does not cause TD. And in fact, before 2017, before the new treatments came up, it was sometimes used for people that develop tardive dyskinesia. So it's not really an antidote, but it can help because the way it interacts with the dopamine receptor is different to other drugs. And over time, it may lead to some improvement. So for some people, it may be a good idea to be used. Today, I would recommend still what's recommended by the guidelines is not to switch to clozapine, but rather to use the drugs that are designed to treat TD. And then they're asking lithium and depakote. So lithium and depakote don't interact with dopamine, so they are not increasing the risk. They have other consequences, and it may be very appropriate to use them, but they are not specifically going to increase the risk of tardive dyskinesia. So yeah, if you're on TD, if you're on clozapine, your risk of tardive dyskinesia is low. Some people that are on clozapine have tardive dyskinesia because they had it from before. They had it from, perhaps they were on a first generation antipsychotic for years, and then they were switched to clozapine. So clozapine may have helped, but may not have completely eliminated the TD. Other circumstances that increase the risk, the mood disorder, and this is very relevant. So the reason this is relevant is that sometimes we see antipsychotics used as augmentation with an SSRI like sertraline to treat depression, and that's, in my opinion, a little bit of a risky proposition because the efficacy of doing that is not tremendous. It's efficacious, but it's not tremendous. And you are increasing the risk of tardive dyskinesia if you're using it long term. So me personally, I avoid doing that. I rather do other things like augmenting even with lithium or trying a different antipsychotic or using TMS, or there are alternatives that I would use to using an antipsychotic on the long run to treat depression. However, there are some people for whom the risk of stopping the antipsychotic is not worth the benefit of not being at risk for tardive dyskinesia. For instance, if you have schizophrenia, most people are going to relapse if they stop the medication, the vast majority. And the danger of relapse is much greater than the 10% risk of developing tardive dyskinesia. So there you have to weigh pros and cons, and you say, okay, I'll use a drug that's less dangerous. Perhaps I'll use a second generation antipsychotic, but I have to still do it because a relapse is going to be far worse than tardive dyskinesia, which most people will not get anyways. Women are also at risk, and intellectual disability, developmental disability it's also another risk factor. So this is something that you should discuss with your psychiatrist. Your psychiatrist should be mindful of this. There are some cases in which a long-term antipsychotic is really still worth, but not always. In some circumstances, if you're like elderly women that have depression and you're using it in combination with sertraline, I wouldn't do that. So there might be some circumstances in which long-term use of antipsychotic may not be the best idea, but there are some others in which that's still worth. How do we diagnose tardive dyskinesia? So there are some criteria, and I want you to be aware. Like I am not going to ask you to diagnose it, but I want you to be aware of what that looks like, and in case that someone that may have this, so that you have a little bit of an orientation of what that might be. So whenever you discuss it with your doctor, you're a little bit better prepared. So there are some criteria. One is that the movements need to be present for at least 4 weeks. Tardive dyskinesia is chronic, it stays for the long run. And if it disappears enough by itself, it's probably not tardive dyskinesia. However, sometimes we see that if you increase the dose of antipsychotic, it gets better. That is different. Okay. Here, what I'm referring is that there is some sort of abnormal movements for 4 weeks. Okay. There needs to be a chronic exposure to antipsychotics. Okay, so that's going to be at least 3 months. If you're younger than 60, if you're older than 60, 1 month. Okay, older people may be more sensitive, and also they may have been on antipsychotics previously. And then the signs of tardive dyskinesia may develop while you're on the antipsychotic, or they may worsen if you stop the antipsychotic. That's also typical. Sometimes you say, all right, you develop tardive dyskinesia, I'm going to stop the offending agent. Turns out that that worsens things. In the long run, it might help, but that's generally not a good idea. Okay, there are alternatives, and I'll tell you what the right way of doing it is. But stopping the offending agent is not the right way of doing it. Okay, as I was saying before, this is something that is often underdiagnosed. And we now have drugs to treat tardive dyskinesia. So in the past, I understand that, okay, we're not going to do systematic screening of it because there's so much I can do about it. But now we have drugs, we have things that we can do to help these people. So it's important that we screen appropriately. And what the APA, the American Psychiatric Association, recommends is that at each clinical assessment, there is an inspection. So the doctor, that's part of the visit, they should be mindful of it at each time that they are seeing the patient. And if they see something, they should explore further. But in addition, it's important that at least once a year, if there's no risk factors, and if there are risk factors twice a year, there is a rating scale, a physical exam that is performed to systematically look at every part of the body and check for these involuntary movements. Yeah. So that is something that should be done at intake or around intake. If there's like no time to do it within the intake, it's something that could be done the next visit, but should be done at baseline, and then should be done every 6 months if there's risk, every year if there's no risk. Just to give you an example, if for a woman that is taking, a woman in their 60s that's taking sertraline and risperidone in augmentation or abilify in augmentation, that person is at risk. They should be doing the screening every 6 months. Uh, Men in their 20s that just started treatment with Abilify, once a year should be enough. Okay. All right. So how is the exam done? So again, I'm not going to teach you how to do the exam, but I want to know what to expect. So the exam is like a physical exam. If you go to a neurologist, they will do a physical exam, right? They will ask you to stretch your hands, to sit in a chair, and that's the same thing we're going to ask here. So we would ask the person that is doing the exam to sit in a chair, put their back against the back of the chair, and to relax with the arms on their lap. And then we will ask a number of things. So because the face is a place where the movements often appear, we do a more thorough exam of the face. So we will do just a visual inspection, but we are also going to ask the person to stick out their tongue. We're going to ask them to stick their tongue while there's finger tapping. So I will say, all right, so now I'm going to ask you to do this like this and look at me. Okay, so I'll ask the person to do that. Okay, now keep doing it and open your mouth. And now keep doing it and stick out your tongue. Okay, and then we will ask the person to take off their socks, to take off their shoes, so that we can observe the toes, because that's also a place where TD could be hiding. We will ask for exam of the hands. Seems that there's another question. Besides lifestyle issues, is there a health risk with TD? Can it be worse if not medicated for? So typically there's burden of TD. Obviously, living with this involuntary movement, especially if it's in the face, that's the face or in the trunk, it can be burdensome. It's very inconvenient. Now, there are some times that it's affecting, for instance, the muscles that for phonation. So it may be difficult to speak if that's interacting with those muscles. It's not going to interact with muscles in the gut or the heart, anything like that. That's not ever going to be affected. But in some rare circumstances, very rare, it may affect the tongue in a bad way or the throat in a bad way, and make it difficult to eat. I think that that's very rare. That's not, again, that would be a very severe case. And then if not medicated for, it may get worse. Yes, it can get worse over time, but there are treatments. So I'll tell you how to manage that in a second. So now going back to the exam, and this is something that I think it would be good if people are aware, so that when they go to their doctors, they ask for it. Okay. Um, we see, as I was saying before, we don't diagnose tardive dyskinesia enough. There are some people that have it that don't know it, and it can be treated. So I think it's important to be familiar with. Okay, for you, you should know that there's an exam. There's something that should be done systematically so that they can observe. And you can, you or your loved one, you could be kind of like keeping an eye and see, like, I'm experiencing this and I don't know where it's coming from. So I want that to be looked at, so you can bring it up to your doctor. But anyways, you will, essentially, the exam consists on these different movements. Some of them are a little bit funny, and it happened to me that I was doing it on someone and I didn't explain it properly, and they thought like I was kind of like making fun of them or mocking them. So just so you know, that's part of the exam, asking you to stick out your tongue and to do this. Okay, so it's not that we're mocking anyone, is that we want to make sure that we can observe the muscles of the tongue, because that's a frequent area that's involved, the mouth, the jaw, under different circumstances. We do this for distraction, really. Sometimes people can suppress the movements if they put an effort into it. So that's why we do some of the distractions, so that if there's like kind of like some mild involuntary movement, that we can observe it. And then there's a rating. I'm not going to go through that, but essentially we rate the different parts of the body, and then we give a score depending on how severe the movements are, and depending on whether there is enough areas involved. And with enough severity, we can say this person does have TD or this person does not have TD. The other thing is that not all involuntary movements are TD. Sometimes there are tics. Tics are different from TD, okay? Tics won't respond to the treatments that we use. So it's also important to exclude some things that looks like like TD, but they are not. And sometimes that's not straightforward, okay? Sometimes doctors may disagree, this is TD or this is not TD. It may not be so obvious. So it's done by clinical exam, and it's not always obvious. Now we are doing this session via Zoom, right? And I'm sure that people see the doctors over Zoom quite frequently. We get the question, okay, this is a physical exam. Can you do this via telehealth? And the answer is yes. You can do it via telehealth. We do it via telehealth all the time. So that should not be a reason not to do it. It just requires a little bit of adapting to the logistics, but it can perfectly be done. Okay. So it obviously should include video, because if there's no video, the doctor cannot observe. And also should be accommodated so that you see the entire body, okay, of the person. So in a phone it's a little more complicated. If you have a tablet or a laptop, you can tilt the screen a little bit so that you see the entire person. Obviously it's easier to do in person, but if you have to do it remotely, it can perfectly be done. And now, what does the APA, the American Psychiatric Association, recommend to manage tardive dyskinesia? So the recommendation is to use reversible VMAT2 inhibitors to treat moderate to severe. Okay, and they can also, moderate to severe TD, they can also be considered in mild TD. But there, in that case, you need to consider the pros and cons. Is it worth or not? And there are other things that we used to do back in the day before 2017, when the two drugs that are in the market were approved. That's valbenazine and deutetrabenazine. Those are the two generic names. Before then, there were sort of things that we used to do, which is not effective. Benztropine, cogentin, not a good idea. Clonazepam, benzodiazepines, not a good idea. You could change to different antipsychotic. That I think still is reasonable. Amantadine, not a lot of efficacy. So really the standard is with these two drugs, valbenazine, deutetrabenazine. The APA is not particularly um, fast, or they don't adopt this decision lightly. The reason it's recommended is that the evidence is very contundent. Okay, it's very clear that these drugs are very efficacious. That's why they are endorsing them, and they are recommended as first line. There are no major differences between the two, the valbenazine or the tetrabenazine. But those are that type of medications, the VMAT2 inhibitors. Those are the drugs that are recommended. And how do the drugs work? So let's go back to the what's wrong. What's the problem? The problem here is that the we have release of dopamine, we have receiving of dopamine, and the receiving end is very sensitive because now you have grown a lot of these new receptors that you didn't have. And not just that they're more sensitive, more thirsty for dopamine. So there's a lot of sensitivity for dopamine, any amount of dopamine that lives here. What do these medications do? The tetrabenazine, valbenazine, they do exactly the same. What they do is that they are called VMAT2 inhibitors because, in essence, they reduce the release of dopamine. So, yes, you have a lot of thirst for dopamine, but you know what? I'm going to produce less. Okay, so here you have, before using the drug, you have these neurons that are that there's a lot of dopamine and there's a lot of thirst for dopamine. So this neuron is very active. Here, what you do is that you decrease the amount of dopamine. So yeah, there's a lot of thirst for dopamine, but there's little dopamine. So despite that high sensitivity, you're not offering too much to that receptor, and that's what is helping. And I'm going to show you the data for the efficacy for the drugs is very similar. There are no major differences in efficacy between the two drugs. They do the same thing. So this is the data for deutetrabenazine, one of the drugs. Here, these are data from a clinical trial. So you have people that have the illness, they have TD, and they are put on this drug at different dosages or placebo, and no one knows who's getting what. Okay, and then we measure and we see how people do. So we don't know, these people don't know they're on placebo. These people don't know that they are in the low dose. These people don't know that they are in the high dose. These people don't know that they are in the intermediate dose. What you see here is that there's a separation, that people are observed for 12 weeks. Those that were by chance put on placebo, they don't have much of an improvement. Those that were on the drug, they have a very dramatic improvement. Okay. If you say, okay, I want to classify those that get at least 30% better and those who don't, or those that get 50% better and those who don't, or those that get dramatically better, those who don't. So you see that there's a separation here, right? So these are the people that are in the low dose or no dose. These are the people that got the drug at a therapeutic dose. There's a big difference. Okay, these drugs are very effective. These are the data for the other drug, for valbenazine. Same thing. And actually here they do something that's clever, that I think is very compelling. They treat people, again, no one knows who's on what, okay? Those that are on placebo, you see, they are not changing. They are the same. You have people that are on intermediate dosages, they improve. There are people that are on high dosages, they improve a lot. But now what they did is that they are going to continue on valbenazine everybody. So even those that did not respond because they were on placebo, so they had nothing to respond to, they now start improving. Okay? And now you are going to wash out everybody. So you stop the drug for everybody. And what you see is that the symptoms bounce back. So to me, this is very compelling. The drug is on, it works. The drug is off, things go back again. So, that's very compelling, it's very efficacious. Obviously, it's a drug and it has side effects with it. So, what are the most common side effects of these drugs? you see sedation in 10 to 30% of those that are taking this VMAT2 medications. You can see depression as well. And in fact, there is a black box warning for suicidality. That is not necessarily because it was observed with the drug, but the FDA will give the black box warning if there's a drug very similar to the one that you're putting in the market that has a black box warning. So in a way, they are inheritable. So deutetrabenazine has that black box warning because tetrabenazine has that black box warning for suicidality. Bottom line is, if you see that there's any worsening of mood, you may consider, okay, is this helping me enough or should I stop it? Insomnia can happen 5 to 10%, not that frequently. And then you have some rare things or some non-specific things like anxiety, Parkinsonism can happen, but it's rare. Akathisia, you may have some orthostatic hypotension, fatigue, so things that are non-specific that may or may not have been caused by the drug actually. So that's what I had for today. Okay. What I want you to walk away with, what are the things I want you to learn? I want you to learn that tardive dyskinesia is an involuntary movement that happens when there is chronic use of antipsychotics. Now, chronic use of antipsychotics may be necessary, so that risk may still be there, but there are some circumstances in which the antipsychotic may not be necessary. Sometimes we are using antipsychotics perhaps too much in children to manage irritability and agitation. So perhaps there are other drugs that could be used instead. There are underlying risk factors. So, older age, women, affective, having depression, that can be another circumstance to consider whether chronic antipsychotic use is a good idea. Second generation antipsychotics, those are drugs like Abilify, risperidone, olanzapine. Those are drugs that have way less risk, but the risk is not zero. And the doctors should be running regular assessments of TD, and because it's underdiagnosed, it's recommendable that there's regular checks just to make sure that it doesn't happen. And again, there are effective drugs for tardive dyskinesia. These are usually well tolerated and they are very efficacious. So if there is moderate, especially if there's moderate to severe, even with mild cases, it may be appropriate to use this drug. So that's what I had for today. And I would like now to open the floor for questions.
Hey, everybody, you have been muted, so if you want to unmute yourself, please go ahead and do so if anybody wants to put. One person did ask in the chat if estrogen levels are protective against TD, of women, if there's any.
That's a very interesting thought. I don't think we have the answer, at least that I know of. Why is it more common in women than men? I don't think we understand very well. It's possible that estrogen is protective, and we know that estrogens are helpful for other things, even for relapse prevention. There are some recent data suggesting that that could be the case. So it's possible, but I don't think we have a definitive answer for it.
Okay. I mean, I know that some of you on here have had experience with loved ones or yourselves with TD. I know for in our family, our loved one experienced TD because he would take himself on and off his antipsychotic. So when he was ramping back up with his, I always just refer to as olanzapine because he was on different versions of Zyprexa. But anyway, when he was ramping back up with this antipsychotic, there would be these arm movements, which were very much described, illustrated by your images there. And then it would go away. But ultimately, to be very frank with you, like all those different meds on that screen were tried. And so he is part of that, at 32 years old, part of that category of, is now on clozapine. because he continually went backwards instead of forwards.
Right.
So and has not had, as indicated, because clozapine works on both serotonin and dopamine. So he
Right.
does not have TD, to date.
Hmm.
Probably won't, I guess. I'm hoping.
Yeah.
So, okay. Nicole has a question.
So, Liz, just one comment. So, what you're saying that they were taking on and off the medication, that might be a risk factor. So, there are some data suggesting that long-acting injectables have lower risk, precisely because the concentration of the drug in the body is super stable. But if you're like taking medication on and off, that could put the body more at risk of developing that sensitivity that causes this. So, like, taking meds on and off is not a great idea because you're really just like increasing the amount of bad things that the medications do without improving the good things. So it's not a good idea. But clozapine, as we discussed, is actually used to be as a treatment. So I'm glad to
Yeah,
hear that's better in clozapine now.
yeah, exactly.
I
Okay.
think Nicole was first.
Yeah.
Um,
Yes.
they raised their
Hi.
hand. Hi.
Hi, Dr. Rubio. I'm just wondering, my son was diagnosed with schizophrenia at 19. He's now 55.
Mhm.
And he went on clozapine when he was 31. So he's been on clozapine for many, many years.
Uh-huh.
And initially they put him on that because he was deemed at that time treatment resistant. So clozapine with the
Mhm.
blood testing was
Right.
the treatment of last resort
Right.
20 some years ago.
Right.
But I'm wondering now why clozapine isn't more widely used if it doesn't have the TD risk.
I wish that I wish that we could use clozapine as much as it should be used. Yes, it's grossly underutilized for a variety of reasons. I think that there is some clozophobia. I think it's mostly among prescribers more than the families. It's a complex situation. It's a combination of there are some side effects. It's a drug that can have a lot of metabolic side effects, etc. And obviously there's agranulocytosis and myocarditis. So there are some side effects that are potentially very dangerous, but the reality, it's a life-saving medications for many people. So it's very unfortunate that's underutilized. And it's a combination of difficulties with access. Sometimes the systems of care are not adequately prepared to deal with the complications of clozapine. Sometimes doctors may not feel comfortable because if something happens, what happens if your white blood count goes to the floor? What do I do? So I think it's frankly an embarrassment to the field that's not used more frequently. And I wish that you know I could have a more positive take on it, but I think it's not. But
Thank you.
yeah,
I have a question.
yeah.
Can an MRI or a CAT scan see if those things can help in treating it and trying to figure out what's going on for people who do
For
have
TD,
yeah.
not really, because it's not that easy. You could see things using very experimental procedures, but it's not something you're gonna be doing on a routine basis. And it's really a physical exam, so it's obvious.
Mm-hmm.
As you saw before in the videos, there might be some cases that are a little more complicated. And is this a tick or is this TD? But for most people, it's not that difficult. So it's really a clinical decision
Mm-hmm.
more
Okay.
than an MRI or an objective measure. David had a question. So we've been told by two experts in TD that giving our son drugs like Osteo can possibly make movements worse. Is this true? um there might be. I mean, the devil is on the details. I've seen people on VMAT2 inhibitors that got their movements worse, but that is under a very concrete alienation of planets. So sometimes there are people that are using concomitant drugs. Like, I sometimes, I know of someone that was using an MDA, and then they use Austedo and they got tremendously Parkinsonized. That can happen. So it's not that the movement disorder got worse, is that now instead of TD, this person have Parkinsonism. And it was very remarkable. Like, the person could barely actually walk, so it can be very dramatic. But that was a very exceptional case. There was, like, this person was taking an NMDA, and I think that that's what caused the problem. Generally speaking, it treats TD. It's not going to make it worse. I don't know if this person is referring to other movement disorders that could happen, but my recommendation would be to get a little bit more of the rationale of why that is happening, and if the TD, if there's TD in fact, I would go for another opinion and have another doctor look at it.
Jose, you refer to different medication classifications, MMD and so forth. So you're suggesting that
You can type it in.
most of our loved ones
Type
are
it
not
in.
necessarily on one medication, right?
Oh,
So
no. So this person was taking ecstasy, a drug of abuse.
Okay.
And that's why the combination of ecstasy with the VMAT2 inhibitor had that paradoxical reaction. But that's very exceptional.
Okay.
Yeah.
Okay.
So another question, can TD progress into frequent grand mal seizures? That's a very good question. And the answer is that if that is what's happening, it's most likely not TD. Because what causes the grand mal seizures is a very different mechanism from TD. So if that's what's happening, I would suspect of something else, but not TD. So the answer is no, not really.
That's interesting. That's interesting. It's somewhat related, but not related. I'm kind of curious. Recently coming up in lots of conversations are schizophrenia, where there is just chronic, catatonia. And if I find it remarkable to think that schizophrenia and catatonia go together like that. Is that really something, or is there something else happening, that is causing catatonia?
Yeah, catatonia is very different. Again, it can also present with some of these movements, right? So in catatonia, you may observe the rigidity. You may observe some stereotypical movements, but they are different. So stereotypical movements in catatonia, they are typically occurring when there's like an overall worsening. So it's not just that the movements got worse, but you perhaps may see some perseveration, or you may see some waxy flexibility. So it goes along with a whole syndrome. It's not the movement in and of itself. And the mechanism is very different. The treatment is very different. Catatonia responds very well to either ECT or benzos, and that's not the case with TD. TD doesn't respond to that. So it's a very different process in the brain, even if it may look similar.
One thing that I thought was interesting about your diagram was that, if it's antipsychotic is suppressing dopamine, but right?
Yes.
So, but the TD medication, whichever variety it is, it was my visual understanding of what you were saying is that the medication is increasing the dopamine.
So imagine that you have, you have a release and you have a receive, right? So I send a signal and I have to listen to the signal, okay? So what happens is that, and if you're using antipsychotics for a long time, I am blocking the receiver, okay? I block the receiver because there's too much dopamine. So I'm blocking it so that on the receiver end, the tone goes down. What happens? That the body says, hey, what's going on? All my receivers are being blocked. I'm going to develop more. So now you have many more receivers, right? And then even any amount of signal that's in that space is going to be picked up because there are so many receivers. So now the signal goes up. Yeah. So what these drugs do is that they decrease the flow of dopamine. So yes, there's the receivers are a lot, but there's less dopamine. So there's less signal for that receiver. And then the tone is going to go down again.
Okay, I gotta ask. So, what are the other side effects of antipsychotics? So, one of them is this involuntary movement.
Right. So antipsychotics, yeah, so there are some side effects that are going to occur early in treatment, some that are going to occur late. The most frequent late side effect is tardive dyskinesia by far. You know? And then there are some specifics, like clozapine has like some very typical, very unusual side effects, or some side effects that happen with clozapine, not with other drugs. But as a class, antipsychotics, the second generations, they are related to they cause weight gain, metabolic disturbance.
You know what, Jose, can you turn your share off so your face, so your face is larger?
Oh, I'm sorry.
Yeah. So the weight gain. So that's one thing that I honestly don't see enough medication for our community for the weight gain. And that's associated with,
Yes.
self-worth in our very vain world, and then maybe diabetes, of course, and heart
Yes.
disease and things
Yes.
like that.
Right.
Is Northwell or the psychiatry department more aggressively addressing that?
There are some options. So recommendations for that is one, now there are drugs that have a much more beneficial profile for weight gain and metabolic side effects. So there are some drugs like lumateperone, Caplyta, that has a much more favorable profile. Lurasidone, Latuda, that has a much more favorable profile. Cobenfy, that has a completely neutral. So Cobenfy has zero weight gain and zero metabolic disturbance. So my recommendation would be use those drugs when possible. If you cannot, I know sometimes there are people that their insurance won't cover those drugs, or whatever circumstance. In that case, I would always recommend metformin. And when metformin is not enough, a GLP-1 agonist. So, for instance, there are some people that will only respond to clozapine. So, if clozapine is your only choice, clozapine brings a lot of weight gain. It's very metabolically, it's horrendous. I mean, it's a very effective drug, but has everybody gains weight on it. So, what you should do is to treat the weight gain with a GLP-1 agonist. And there are more options. They work very well. The weight loss is dramatic, and the normalization of all the metabolic parameters is dramatic. So if my loved one has to be on clozapine or has to be on a drug that has a disfavorable metabolic profile, I would say push for a GLP-1 agonist. As your doctor, as your primary care provider, push for it, because you should try first metformin, but if that doesn't work, I would go ahead and be pushy for the GLP-1.
I mean, any do-it-yourself herbal supplements can help.
I would advise against that. And the reason is that it's going to distract you from things that are effective. The do-it-yourself herbal supplements, they've been studied and they don't really make a big difference. So when you're talking about things that are severe, like TD is no joke. The weight gain is no joke. Diabetes, especially, you're a young person. You have diabetes when you're type 2 diabetes at 30, which could be preventable. That's not a joke. So, I wouldn't I wouldn't get distracted by other solutions. I would go to things that have been proven by science. So we're talking about weight gain. I would go to metformin and then GLP-1 agonist.
Yeah.
Sometimes trying to find something that's more friendly, it's actually a distraction from something that's more effective.
Can you talk a little bit about, is it Comvy? That's like sort of the newest medication, on the block. And, there's not a whole lot of people that I know whose loved one is on it, because there's still a little bit of hesitancy because there's no track record yet.
Yeah,
So,
I mean, so
um,
we are running a study on Cobenfy, and by the way, I consult for the company, so I have a conflict of interest. Still, I think the data is very solid. It's a new class of medication, so I told, and actually I'm gonna have to go in a minute, but I told you that all the medications, they interact with dopamine, right? So they block the receptor of dopamine. Cobenfy is the only drug that does something very, very different. It works upstream, and it's kind of like going more to the root of the problem, so to speak, and it doesn't have the off-target effects. So it doesn't have any of the weight gain, no TD, no involuntary movements, no hyperprolactinemia, no gynecomastia. So it's very, I mean, the only thing that it has is nausea, constipation. So there are some other side effects that tend to go away. Um, but I think the data are very impressive.
so there's a huge audience here that would love for you to, especially if you are consulting with the pharmaceutical company, to test it against clozapine and just give us the answer.
I actually reached out to them because you know that 30% of Cobenfy in the US is used on top of clozapine. So this is like the usual situation is, clozapine is helping, but there's still this or that problem. Let's put Cobenfy on. So that's 30% of the case of the test case. And the other 20% is on same thing, but on olanzapine.
Okay.
So um, I actually asked the company about it, and they're not going to do it now, but they may do it in the future.
Hey, if you want a group of people to sign up or form or request it, you've got 100 people in our community that would do it immediately.
Yeah.
Yeah,
Yeah. I mean,
now,
I have that question
outside.
myself, but um, yeah, I mean,
I'm serious. I'm very
I
serious.
know, yeah, but running studies now, we need the money to run the study, right?
No, I know, but you also need a whatever. You need the request for it, and show,
I think it may happen. I mean, I spoke with the company, and we are, I'm not the first person that brings that up
yeah,
because,
for sure. No, as a community, we've spoken a lot about it.
yeah,
And both, NAMI members as well as the Psychosis Alliance and all of this, collective um, are very interested in that
yeah,
because we live in the world of side effects, Jose.
yes, and yeah, I mean, and you have like younger people, or older people are more sensitive to them. Younger people, yeah, what does it mean to develop this, like, diabetes when you're so young? So it's, and let's remember that this has long-term consequences because life expectancy is reduced when you're dealing with obesity and all of these problems, right? So we need to take that seriously, especially from early on. So we're actually doing a study that's testing Cobenfy in younger people precisely because we think that it may have more favorable profile in the long run.
Right.
So we are running that study in Hillside.
Okay. Well, good to know. We need to know more about that. We'll
Sure.
happily share. Because it gives people hope, I think that we will need to learn obviously as much as we can, and I think a lot of us do try to do that, but basic science and research gives us all hope.
Yes,
And,
that's the only way forward.
yeah, we
Thank
have.
you very much. You made things very understandable. Appreciated.
Okay, happy to hear that.
Thank you, Nicole.
Thanks
Yes,
very much. Very interesting.
yeah, thank you.
Okay,
Thank you very
happy
much.
happy to
Appreciate it.
help, and I'm
Um,
happy to come back if you think I can be of help.
yeah, you know what? I would love to have another talk about the
When
research.
you watch, yeah, I can hear you.
I think that would be really helpful. So everybody, thank you so much for joining
Thank
us.
you.
Thank you,
Thank you.
thank you.
Thank you.
And I expect to see you all at our meeting at the 29th about the very much mentioned clozapine, because it'll be a hybrid meeting, and at NAMI Fest on November 2nd at Northwells, Sloman Auditorium. It's going to be a wonderful day. And both honoring again Vera Pure, who's psychiatrist at Cohen's Medical Center, as well as live entertainment, which will be 3 therapists dressed up for children. That'll be interesting. And they're wonderful performers, and just all in all fun, and honoring our community and people who've been working really hard in our peer groups with the Unites. We really look forward to all of our peers sharing their story about what NAMI's done for them, but more importantly, how well they are doing